Welcome everyone to our online information and support session. My name is Kathleen Helgeson and I'm the coordinator of the Patient and Family Resource Center. And I'm joined tonight by Dr. Ann Katz, author and sexuality counselor here at Cancer Care Manitoba, who will be sharing her knowledge and leading our discussion about changes in sexuality from prostate cancer. We are very pleased to offer this session with the generous funding support of the Cancer Care Manitoba Foundation. I'd also like to take this opportunity to acknowledge that we're meeting from all regions in Manitoba, the traditional land of the Anishinaabe, Cree, Ojibwe, and Dene people, as well as the homeland of the Métis Nation. It's important for us to foster inclusivity and reconciliation and encourage others to do the same. Before we continue, there are a few basic Zoom features I'd like to explain. You'll notice as an attendee, your microphone and your video are turned off. If you have a question for Dr. Katz at any time during the discussion, just type your question into the Q&A icon at the bottom of your screen, or maybe at the top of your screen, depending on your view, and we will be able to answer your question. You can also ask that question anonymously by checking the Send Anonymously box before you click on the blue arrow to send. My coworker, Ellie, is also here off screen, and she will be helping manage your questions as they come in. If you have a technical concern, you can also ask Ellie in the Q&A, and she will answer your question privately and try to assist you. It's my pleasure to introduce Dr. Ann Katz. Ann is an author as well as a sexuality counselor. She has written over a dozen books, has her own podcast as well, and she is an international teacher, speaker, and researcher. I guess I'm just somewhat, yeah. We are very privileged that she has been based here at Cancer Care for over 20 years as our very own sexuality counselor. Welcome, Ann. Sorry, I muffled your introduction a little bit there.
That's okay, Kathleen. We know each other well. So thank you so much for inviting me to do this. I'm also the clinical nurse specialist at the Manitoba Prostate Center. So I have multiple hats. And in that role, I help men newly diagnosed make a treatment decision. And I think we're going to be talking a little bit about that later in the context of couples. Perhaps just at the outset, I want to say that when I talk about a couple, it could be a man and a woman, two men, it could be common law, it could be married for 62 years, and good for you if you've managed to stick it out that long. So I use words like partner because I want to be inclusive. So this really does, the information that I'm going to provide, I hope will really, be inclusive of everyone who may be on this listening today.
Thank you, Ann. You've been really prolific in your writing about sexuality and cancer. And, just for those of you that don't know you, just if you could explain a little bit what drew you into this line of work and what's kept you inspired.
So many, many moons ago, I think it's actually now 22 years, which really scares me. I finished my PhD and wanted to continue learning because, once you've spent so many years at university, it's somehow difficult to think that, you're not going to study anymore. So I did a sex therapy program at the University of Guelph and decided that I needed to use it in some way, shape, or form, and really look for an opportunity within a population that really needed help. And through a search of the medical literature, cancer popped up, and I started working 1 day a week at Cancer Care Manitoba. What has kept me doing this is just the people that I meet and the couples and individuals that I support, educate, counsel. It really keeps me going after all these years. And every day I learn something new, which I think is a huge privilege.
So we have a question already from somebody in our audience asked you, what is your PhD in exactly?
So I did an interdisciplinary PhD. I'm a nurse by background. And at the time, there was no PhD in nursing. There is now. So my interdisciplinary PhD comprised medical microbiology, don't ask why, sociology, and nursing. And I actually looked at something that I've never been involved with since then. So I looked at the whole issue of HIV screening in pregnancy. Oncology, cancer care has just really filled my soul and made my brain explode on occasion. And I really do love this work.
One of the things that that you've mentioned when we had actually some people may have actually participated in one of the last webinars we had, which was on body image and cancer, and I know that at that time we had had sort of received questions specific to prostate cancer. But one of the things that you've mentioned is that prostate cancer is often termed as a couple's cancer. Can you tell us why that is?
I'm not sure why that is really, because I believe that if you are part of a couple and one of you, male, female, gets cancer, it's absolutely a couple's disease, because a diagnosis of cancer and certainly the treatment turns your life upside down. So I think in part, it's called a couple's disease because it's based on the sexual side effects of treatment for prostate cancer, with the assumption that it is the man who is the initiator in that department. So I really do think that it's an inaccurate description, but if it's a segue into talking about the side effects of treatment, well, there it is. I think it's just slightly inaccurate, just thinking of this one particular cancer.
And do you think that it has more of an impact on the couple's relationship than other cancers, the side effects?
Well, if we assume that the male in a heterosexual relationship is the initiator of sexual contact and he's experiencing sexual difficulties, perhaps it makes sense that way. It's not a particularly sort of favorite descriptor for me.
Mm-hmm. Yeah. We're going to talk about side effects of treatment and the different types of treatments. So we thought it might be a good idea to poll our audience, first of all, to get a sense of what type of treatments people have experienced. So I'm just going to do that now, launch the poll. So should be now seeing that on your screen, and just if you don't see the poll coming up on your screen, it just may be that your computer doesn't support it. You can also share a comment in the Q&A and Ellie will relay it to us. So asking what type of treatment you've received for your prostate cancer, either active surveillance, surgery, radiation, androgen deprivation therapy, and if you've had multiple types of treatment, then you can select more than one. So, Anne, it looks like we have about 23 people that are participating right now. So
I'm hoping it's 23 couples.
Mm-hmm. So we've got almost all our respondents in. So what I'm going to do is I'm going to end the poll and then share the results with everybody. Go. And Anna, are you able to see that?
Yes, I can see that.
Sure.
Yeah, so it's really interesting to me that we have essentially the same number of men on active surveillance as have had surgery. And that really does make me happy, because we know historically, and I'm not talking from the 1800s, probably in the last 30 years, we have really overtreated prostate cancer. So that means that there are, what I mean by that is that there are men with low risk cancer, and so that would be Gleason 3 + 3 = 6 cancer. We can really delay or defer treatment for as long as possible by doing this active surveillance, which does not mean, go away and come back when you have symptoms. What it means is we actively monitor through measuring the PSA regularly, doing biopsies on a fairly regular basis. And in that way, we can delay active treatment. And sometimes we can actually delay surgery or radiation for the rest of the man's life. So I'm really happy to see that more men now are doing this active surveillance. So, surgery, radiation, Those are the most common treatments for prostate cancer. And I see we've got about a third of men who are on androgen deprivation therapy. And that is often given in conjunction with radiation therapy, particularly for men over the age of 70. We tend not to do surgery on men over the age of 70. And I know it sounds ageist, but there's a really, really good reason for this. And if someone wants to know why, I'll answer the question in a little bit. So I think this is a really interesting spread and makes me happy.
That's great. Yeah. Let's talk a little bit about, I'm just going to stop sharing those now, but let's talk a little bit about surgery. And I have a question, because when I've been reading in your books the term radical prostatectomy, I was thinking, how is it not radical? Like, is there a non-radical, or is there, why is it called that?
There is a non-radical prostatectomy. So for the treatment of benign prostatic hypertrophy, enlargement of the prostate, which happens as men age, and the prostate will enlarge outward as well as inward, and it squishes the urethra, or the tube that you urinate through. So they can actually scoop out parts of the prostate to widen that passage. But a radical prostatectomy involves surgical removal of the entire prostate gland, as well as the seminal vesicles, which are two little glands. I think of them as sort of like angel wings that are attached to the prostate, where the fluid portion of the ejaculate is stored. So the radical prostatectomy involves an incision above and below the prostate, and the two ends of this tube of the urethra are sewn together like a garden hose. It's big surgery. The prostate is deep in the pelvis. They have to go through the abdominal wall. And so there are quite significant side effects of the radical prostatectomy.
What are some of the what is the impact after someone has had that procedure done in terms of the side effects?
So the two major side effects are incontinence or bladder leakage, and erectile dysfunction, or the inability to achieve an erection. So the incontinence happens because the valve or sphincter, and it's not like a car valve. I'm actually not sure what a car valve looks like, but it's a group of muscle fibers that keep the bladder closed. So the bladder sits on top of the prostate. And so the sphincter is damaged, sometimes actually removed, depending on where it is located, at the time of the surgery. The muscles of the pelvic floor have to take over the function of that sphincter and keep the bladder closed. So depending on the tone of the muscles of the pelvic floor, which run in a sling from the pubic bone in the front to the tailbone at the back, and the bladder kind of sits on top of that, those muscles have to be in good tone. So for men, for example, who do a lot of weightlifting, perhaps are ballet dancers, those muscles, or men who work out a lot, the muscles can be really, really tight, which is not good. For other men, particularly men who have a bit of a tummy, those muscles can be loose, which is also not good. So we send all the men who are going to have surgery, who see us at the Manitoba Prostate Center, we send them to a pelvic floor physiotherapist ahead of the surgery to do an assessment of those muscles and to give the men pelvic floor exercises to get it into the pelvic floor into good tone, so it can be effective at keeping the bladder closed. For some men, there is bladder leakage, and bladder leakage can be social, right? People can see. Most men are justifiably scared that they're going to be in a diaper for the rest of their life, and we see that very, very rarely, particularly in men who've been to the pelvic floor physiotherapist. The other major side effect of the surgery is erectile problems. The nerves that run on the outside of the prostate and then toward the penis are responsible for erections. Erections are a combination of nerves and blood vessels. So during the surgery, those, even though they talk about nerve-sparing surgery, and I'm sure the audience has all heard about nerve-sparing surgery, it's a little bit of a misnomer, because even though they don't cut through the nerves which run on the outside of the prostate, there's pushing and pulling and traction, etc., during the surgery, and those nerves may lose their own blood supply or are really damaged. And this results in the inability to have an erection. There's also a big psychological component to this. So because men are anxious to have erections, they kind of psych themselves out. So it's part physical, but there's a big mental, emotional aspect to that too.
So that's another question I had about this term, like nerve sparing surgery. How do you know that the surgeon is going to be able to do that? Does it vary from patient to patient? Is there a certain amount of nerves that need to be spared in order for there to be, the ability to have erections after that?
That's a great question. So, it it depends. You're going to hear a lot of "it depends," right, from me. So, and I don't mean depends in the diaper way. I actually just saw a commercial on television just before the news about they're now calling male depends something else, and they've got a somewhat sexy male kind of model on the cover of the product. Anyway, that tells you that this is an issue for a lot of men. Right.
Mm-hmm.
So this is not uncommon, but when it happens to men, they feel very much alone.
Mm-hmm.
So it depends. It depends in part on where the cancer is in the prostate. If the cancer is very close to the capsule or the outside of the prostate gland, the surgeon may not be able to spare the nerves. Now, the nerves cannot be seen with the naked eye. The nerves run along with blood vessels, both arteries and veins, in what we call a neurovascular bundle, nerves and blood vessels. They run on the outside. The surgeon really can't see them particularly well. And so what they try and do is move those, away from where they are doing all the cutting, etc. It also in part depends on the surgeon's skill and whether the surgeon was trained to do this. So, can I tell you that, there's 100% nerve sparing where they can? It's a really difficult assessment to make. Certainly the surgeons at the Manitoba Prostate Center in their operative report, which I read when I have a patient, it'll say 75% nerve sparing on the left-hand side and 85% on the right, generally. But then what happens thereafter is not necessarily under anyone's control, including the man himself. So what tends to happen after the surgery is that while those nerves are in shock and perhaps undergoing a very, very slow recovery, men do not have the erections that they usually have as part of their sleep cycle. We call those nocturnal erections. The purpose of those are not to wake your partner. And often it happens when men get up to go to the bathroom to urinate during the night. And we're not sure whether it's the erection that wakes them and then they go to the bathroom, or it's somehow related to a full bladder. But the purpose of those erections are to keep blood flow to the penis when the man is horizontal. During the day, when he's vertical, there's gravity. At night, when you're horizontal, there isn't gravity. So, the body is this miraculous thing that has compensatory mechanisms for all kinds of things. So during the night, most men will have 2, 3, 4 erections as part of their sleep cycle. It changes as men age. And so when those erections are not happening, we see that the tissues of the penis are actually starved of oxygen and other nutrients. And we see changes in the tissues of the penis, and they become almost like scar tissue. We call it fibrosis, which just means replacement of normal tissue by this sort of less responsive tissue. And we see penile shrinkage. I tell all the men that I see for treatment decision-making, I warn them about this, because men have a nasty habit of looking at themselves naked in the mirror. Unlike many women, we avoid it, but men tend to look at themselves in the mirror. And, penile shrinkage is not a joke. It impacts on masculine self-image. For some men, it can mean that they can't urinate standing up. They have to sit down to urinate. which I think is a pretty good idea, but it avoids dripping and messing in the bathroom. But if you need to use a public washroom, it can be problematic.
Mm-hmm. So the shrinkage that men experience, it's due to the nerves, the impact on the nerves. Could you explain that a little bit?
Yeah, it's because of lack of blood flow.
Okay.
Because the nerves aren't working, particularly at night.
Right. So are we gonna talk a little bit about what can be done for that later on in the? Okay,
sure.
Sounds good. There's a question relating to that I'm also gonna leave for a little bit later in our discussion, but let's move on, just talking a little bit about radiation and the impact of that
right.
on the individual.
So radiation is a non-invasive treatment. It is highly effective, otherwise we wouldn't be offering it, right? And we offer radiation to men over the age of 70 because we don't want them to have to undergo the very, very rigorous surgery where there can be quite a lot of blood loss. And we honestly, as you can imagine, we do not want to do any harm. So we would hate for a patient to, for example, have a stroke or a heart attack while they're under anesthetic, and that can happen. So we're not being ageist. We have sound evidence for this. So the radiation, there are different kinds of radiation. So there's brachytherapy. Brachy means close, and in brachytherapy, very small seeds. Seeds a little bit of an inaccurate term. The seeds themselves look like little pieces of pencil lead. If you can imagine, an HB pencil chopped up into pieces about 1 centimeter. Yes, almost 1 centimeter long. And those seeds are radioactive. They're stainless steel and they contain a radioactive source. And those are implanted, sometimes 100, 125 into the prostate. And the radiation is emitted from each seed. And the radiation basically stops all the cells, cancer cells, as well as healthy prostate cells, from reproducing. So the prostate then, there's often sort of an initial almost inflammation, and then the prostate itself will shrink. So that's the brachytherapy. Then there's also external beam radiation, where the man lies on a table in one of our radiation treatment rooms, and the linear accelerator passes around 360 degrees with the beams specifically targeted at the prostate itself. And we are here in Winnipeg, we are doing a new and exciting form of radiation therapy where the man gets 5 treatments over 2 weeks. The longer course can be 36 or 42 treatments, Monday through Friday, so around 7 or 8 weeks. But this stereotactic body radiation therapy, SBRT, is something really quite new. So that's 5 treatments over 2 weeks. And as you can imagine, people really like that.
Sounds pretty intense.
It is,
yeah.
Once again, highly targeted. And, but to have to come every second day for 2 weeks is perhaps better than, it all depends. Our patients certainly tell me that they love the radiation therapists who are so kind and get to know them over the 7 or 8 weeks of treatment. And so, I guess if you really want to form a good friendship with those radiation therapists, opt for the long course.
Is there any difference in the treatment, this new treatment, as opposed to the treatment that takes the longer course, or is it just more intense and more concentrated?
Yeah, it's just more intense and concentrated. And there's a lot to radiation therapy. It's, you have to be an expert in physics to actually understand the ABC all the way to Z of it. And I don't always understand a lot of it. It's hard, it's really, you got to know your physics. And we have radiation physicists that help with the planning of the treatment to minimize the damage to adjacent tissues.
So what would be the impact of radiation, and how would that affect somebody in a relationship?
So what we tend to see with the radiation is what we call irritative symptoms. So the man may have an irritable bladder for a while, and we have medication to treat that because the bladder is a muscle. It's not a balloon, and we have medication that calm the muscles of the bladder, and it's routine to actually give men medication for that. There can also be some irritation of the rectum. So we want men to be eating a low fiber diet when they're having the radiation. And once again, we have treatments. The body does heal itself though. And most men, like 90 to 95% of men, don't have any long-term effects. In terms of sexual side effects, for the first year or two, most men function in terms of erections the same as they did before. And you see a gradual decline. And frankly, a lot of men just think it's related to aging.
So are there any issues with irritation of the bowel or with incontinence with radiation at all?
We generally don't see incontinence. We see the irritability, so the need to go to the bathroom more frequently. Some men may experience some pain when they urinate, a kind of burning sensation, but it does pass.
Okay. And how about what we call androgen deprivation therapy? Can you speak a little bit about that and what the side effects are of that?
Sure. So androgen deprivation therapy, which is commonly called hormone therapy, which once again is inaccurate. I think hormone therapy, and many women understand hormone therapy is we give you hormones through the menopausal transition and in the postmenopausal period. With androgen deprivation, we're doing the exact opposite. We are depriving the man of an androgen, testosterone. So prostate cancer needs testosterone in order to grow. So in order to stop the growth of prostate cancer, in certain men, and there are certain criteria, we deprive them of testosterone. So there are global side effects from this. By global, I mean something that affects the whole body. So most commonly, we see profound loss of libido or sexual desire. We see profound erectile dysfunction. And then there are a whole lot of other side effects that are what we call systemic. So men will have hot flashes. So women who have gone through menopause will understand that. It's worse for men because they have many more sweat glands. So hot flashes, which sometimes men will sweat profusely, disturbs their sleep. And if it disturbs the man's sleep, it's probably going to disturb his partner's sleep as well. And then you have two grouchy people. A lot of men say that they're more sensitive, they're more emotional. And some men don't mind this, other men do. And in fact, just the other day, a gentleman said to me that, when he's watching a movie on television, he starts to cry and doesn't sit that well with him. He doesn't, and this is part of what society tells men that they have to be, right? Big and strong and unemotional. And we know men are not like that. The men have a sensitive side too, even if they try and hide it really well. Some men have some memory loss. And of course, the first thing that they and their family members think of is, oh my goodness, does dad or does my partner have Alzheimer's? And it's not Alzheimer's. It's just short-term memory loss. And, many women have that too. After menopause, we kind of forget stuff. I went to the hairdresser on the wrong day today. So there you go.
You're part of the club around here. We've all been complaining of the same thing.
Oh, yeah. I was so embarrassed. And of course, my hairdresser didn't tell me until just before I left. He said, oh, and by the way, and you were supposed to come tomorrow. It was just, honestly, I'm like, oh, my goodness. I just entered the wrong date into my phone. What can I say? What else? Some men experience what we call visuospatial problems. So, for example, they go to put down their coffee mug on the table and they kind of miss the table and the coffee mug can fall. So, varied side effects. Not everybody will get, the forgetfulness, but generally flashes are really common. The sensitivity is really common. And then the sexual side effects as well.
What about changes to the body? Does it affect muscle mass or weight gain at all as well?
Yes, thank you for mentioning that. So men will also lose upper body muscle mass, and it's almost kind of like it kind of drops and they get the spare tire obesity. And there's some men who have said to me, I had to buy a whole new wardrobe because previously I would wear like a knit polo shirt or a t-shirt, and I've put on weight. They can have some breast enlargement as well. So this gentleman had to buy a whole wardrobe of cotton shirts because that wouldn't show his body so much, and that can be really distressing. We strongly encourage, in fact, I would suggest we prescribe weight-bearing exercise as well as resistant exercise for the upper body to help mitigate that upper body muscle mass loss.
So these are, there's quite a lot of side effects from these treatments. And I'm just wondering, we have some brochures and information here in the library, apart from your book, some of the, that are much more detailed. But some of the brochures that I've seen don't go into a lot of detail about some of the side effects. I'm just wondering how informed people are when they're making the decisions about treatment.
Yeah, so it sounds to me like you don't have the brochures that we have in the Manitoba Prostate Center, which I actually developed, which explains in great detail all these side effects. Because yes, it's sometimes they kind of soft soap things, and that really bothers me. I believe that everybody has a right to know the beginning, middle, and end of side effects. It's important to be informed. It's important for their family members to be informed as well. So, a huge part of what I do is education of the man, his partner, and often family members as well.
So when that discussion happens, is that led by the doctor or the nurse that's involved? Like, who leads that discussion in terms of sexuality and prostate cancer when someone is just getting diagnosis and is looking at treatment options?
It's a variety of people. We really do work as a team. I would like to think that everybody gives the same information, but sometimes things are missed. And the other thing, it's the timing of the information. We know that after someone hears the 3 words, "you have cancer," they hear 10% of what comes next. So often what we do is we tell people, we give them all this information after those 3 words. And then we, healthcare providers, think, tick, I told them about this, tick, I told them about that. And very often people just don't remember. So it's always a good idea to ask questions. Certainly, a lot of people go online to Dr. Google, who we're not sure where Dr. Google got their medical degree from, but certainly, the Canadian Cancer Society has good information, good evidence-based information. There's Prostate Cancer Canada has good information. There's some American organizations. One that used to be called US2 is now called Zero Cancer, has good information. The BC Cancer Agency, for example. So it's really important to be informed. And if you have questions, ask to see the doctor and say, I have questions. Tell them at the beginning of the appointment so that they know they have to stick around a little bit and answer those questions, or just come and see me. So, that part of my job, which is involved in treatment decision-making, is really about providing information, education, so that the man can make an informed choice.
We have a question from one of our audience members about the comment was that even when both are initiates in sexual play, the thought of erectile failure is a major inhibitor, especially for the male. But it can be an inhibitor for the female as well, I suppose, if you think that you're putting some pressure on the male in terms of performance, and this idea that it's not going to happen. You may just not want to even go there.
Yeah, absolutely. It can set up a really fragile dynamic within the couple. So, what I often hear from men is, I had surgery, I'm not having erections, and I just have no desire anymore. And that is what we call reactive loss of desire, because the man's thinking, well, if I can't do something, why would I want it, right? And what I see a lot in couples is exactly what you described. The partner doesn't want to initiate, doesn't want to put pressure on the man, very often will blame him or herself. Oh, it's because I've gained 5 pounds, or, whatever. I've had partners say to me, I'm sure he's having an affair, you know, and nothing could be further from the truth. And that is why communication is so important. And often I think that, you know, whereas I'm a certified sexuality counselor, sometimes I think I'm a communication counselor, because really a huge part of my practice is just getting people to talk to each other, because otherwise we make assumptions about what our partner is thinking and feeling, and we get it wrong 80 to 90% of the time. And I know, because I'm part of a couple.
Right.
You know, we think we know this person so well. We've been together for 10, 15, 20, 40, 50 years. We know what they're thinking, and we don't always.
A lot of mind reading that goes on.
Yeah, and you know, we're not trained to read minds.
No.
Yeah.
And when you talk about loss of libido, what is the percentage, you know, that in terms of the impact through prostate cancer? How many men would you say percentage-wise experience a loss of libido?
We really don't have good data on that for men who've had surgery or radiation, but we know for men who are on androgen deprivation, 85 to 90% are going to experience loss of libido. And it's not just about sex. It's also about, you know, the normal stuff that men tell me goes through their brain. So the other day, a patient said to me, you know what, a woman could walk naked past my window and I wouldn't even notice. And I think it's that, you know, really, well, subtle or perhaps not so subtle change in the way the man experiences his life. So sexual thoughts and fantasies, gone, right? Desire for partner, gone. And it was beautifully described many years ago in an article written by a urologist who was on androgen deprivation because he had high-risk prostate cancer. And he talked about a world gone gray, which I thought was just a really interesting way. You know, it's like his world had lost color. And the color was noticing an attractive woman, noticing his partner, etc., etc. You know, having those fleeting thoughts or not so fleeting thoughts and fantasies gone.
Right. Is hormone treatment permanent, or can a patient regain sexual functioning? That's a question from one of our audience.
That's a really interesting question. So there was actually a study published fairly recently that talked about the return to baseline testosterone level. So this is how, you know, we're assuming that the testosterone level in a man's blood is a proxy for sexual desire. Maybe. The study found that about only 25% of men will see their testosterone level when androgen deprivation therapy is over. And you know what? Generally, we give androgen deprivation therapy at the most for about 2 years. So when it's given with external beam, generally 18 months to 2 years. This, of course, is negotiable. If the man is having terrible side effects, he can always say, listen, I don't want another injection. The injections that are given, generally, you have the medication in your bloodstream for 3 or 4 months. There are different formulations of the injection, but generally 3 or 4 months. So, you know, you have to wait 3 or 4 months after the last injection to start to see a rise in testosterone. And, you know, if a man is in his 70s or 80s, his testosterone level is going to be pretty low anyway. So the return is going to be to a low level. And then when you accompany that, perhaps with loss of erections, you're also going to have some reactive loss of libido. So, you know, it's complicated.
Yeah. And there was another question asking about how long do the effects of androgen therapy last? Would that include all the effects that you described before, like the hot flashes, the weight gain? Do those things continue on as well, or do they subside?
So, you know, the weight gain tends to persist. Really important to get physical exercise, physical activity into every day, because that can help, you know, to a certain extent to prevent the weight gain. Men generally can eat like they used to before. And the hot flashes, unfortunately, can persist for years. So this is a question that I am commonly asked. You know, I was done. I had my last injection November of last year, and now it's May. So November, December, January, February, March. So it's been 2 months, and I'm still having these hot flashes. It's, you know, it extremely bothersome.
How do people cope with these changes and these challenges?
once again, it depends. There's a whole range. You know, human beings are adaptable, right? We get used to things. So, you know, people cope to a greater or lesser extent. Some people are really distressed. Some people are really depressed. It is rare for me to see relationships break up because of this. Remember, I only see people who want help for what's going on, right? I don't see the people who are perfectly fine. And I don't see the people who've just absolutely given up. So I see what we would call a clinical population. So people who are seeking care for this. Yeah, you know, I am one of the important things that I think that couples need to do is to actively mourn what has been lost, the spontaneity, the ease, right? The usual way of doing things, whatever that was. So really actively mourning, grieving what has been lost allows couples to move on with a new way of functioning. If the couple is solely focused on, penis in whatever, in penetrative intercourse, they're going to struggle.
Mm-hmm. Let's introduce our second poll, and just to check in with our audience about what barriers they've experienced in terms of seeking help. So I'm going to launch that.
Yeah. Good question.
Yeah, so here we have some, and again, if the answer isn't reflected here, your comment, just feel free to share it in the Q&A, and then I will relay it to Anne. So shyness, I'm just glad to be alive. My oncology care provider hasn't asked. It's a private, awkward issue. And sorry, Dr. Katz, just a question as well while we're waiting for those results. Is Prostate Cancer Research Institute, PCRI, in the US a good source of educational material about prostate cancer?
That really may focus on research studies. I mean, I think it's certainly worth a whirl. Go and look and see if it meets your needs.
Mm-hmm.
There's often good information on Medscape, which is targeted sort of at the general public. So that's another place. You've just got to be able to differentiate between, for example, treatments that are offered in the US and in Canada, because they don't, they are often not the same. There's certainly more uptake of experimental therapies in the US than there are in Canada, and you pay for them. So, that's also important.
Yeah. Are there clinical trials here relating to prostate?
Yeah, there absolutely are clinical trials, and the Manitoba Prostate Center, actually, we have our own little research unit, and so there's research studies running there, as well as the clinical trials unit at Cancer Care Manitoba also has some of those studies. A lot of the research now is looking at treatments for advanced or metastatic cancer, because frankly, that's where the money is. So, we don't see a lot of research, comparing radiation to surgery for a whole lot of reasons. But certainly in terms of medication, and, just in the last 2 years, we've really seen sort of second, third, and even fourth line treatment for advanced or metastatic prostate cancer become available in Manitoba.
Good. All right. I'm just going to share the poll with you.
Sure.
So there we go. Dr. Katz, can you see that?
Not yet.
There we go.
Oh, interesting. Well, first of all, I'm really pleased to see that oncology care providers are asking about this. Phew! That really does, make me happy and pleased. There's something I think that happens when a male urologist or radiation oncologist asks a male patient about their sexual function. There is often a reluctance to admit that there are problems for a number of reasons. I think often men don't want to make the doctor feel awkward because they saved his life, so I don't want to point out that things aren't great. It's important to tell the truth, because that's how you'll get help. Bothers me a little bit to see, 56% of respondents are saying, I'm just glad to be alive. I want everyone to be fully alive. And that includes, having a connected, and I was just about to say intimate relationship with a partner. And I always kind of bristle at the use of the word intimate in place of sexual activity, because intimacy really means emotional connection. And for some couples, that's where the emotional connection comes from, right? It comes from touch and fooling around. So I want people to have full lives. When I hear someone say, I'm just glad to be alive, to me, that says nobody has offered you help, right? Because I don't think, I hate to think that this is some kind of bargain that you make, because the treatments are effective. Most men die with prostate cancer, not of prostate cancer, particularly these days where, it really tends to be caught quite early. About a third of people are shy. Well, you got to get over yourselves, gentlemen. This is something that we're used to talking about. I'm really happy to talk about this. And if you're particularly shy, we can have an appointment on the phone. Because of COVID, I'm not seeing people in person. I have a very small office, and we would be sitting on top of each other, and that doesn't make me particularly happy. I also hate having to wear a mask when I'm talking to people, because they have to wear a mask and then I can't see your whole face. So I prefer to do video appointments, because then you can see me and I can see you and your partner, and I can try and read body language. Some people are really good at hiding that. I do miss in-person visits, though. I really do. I haven't done them really now for over 2 years, and I miss shaking hands. Even though people say we shouldn't ever shake hands again, I kind of miss it. It's a private, awkward issue. Yeah, it's a private issue, but if you keep it private, you won't get help.
Okay, yes, very much. I'm going to stop sharing that. We have a question that sort of segues nicely into our next part of our discussion, asking about Viagra and what if it doesn't work? Is there any other solution for someone that still has a healthy desire? So is it safe to take those during treatment, Viagra?
Yes, it's generally safe. Really, the only men who should not take Viagra are men who are using nitrates for chest pain or angina on a regular basis, because the Viagra causes blood vessels to open up, which can then lower blood pressure, right? And nitrates do the same thing, nitrates for chest pain, because chest pain is caused by the blood vessels constricting the blood vessels to the heart. Unfortunately, drugs like Viagra, Cialis, Levitra don't work particularly well. We think that for men after the surgery, maybe 40% of men find these medications effective. Tends to be much less for men who are on androgen deprivation therapy, because there is involvement of testosterone in erections. It's it's a very complicated cellular enzyme, blah, blah, blah. But there are other options. The one is the penile pump, and I'll tell you right now that I'm not a huge fan. It's really mechanical and disruptive. You have to put a very tight constriction band on the base of the penis, which hurts, and the penis will feel cold. And that constriction band can only stay on for 30 minutes. So it really is disruptive, right? You would start fooling around, and then you've got to say, excuse me, I've got to go get this thing. So I'm not a fan. There's also a little pellet that is placed into the urethra. I'm also not a fan. They are hugely expensive, which I think is just absolutely, a crying shame. And we can talk more about that in a minute, because the pills are also expensive. And something that we use a lot of is penile self-injection. And I can imagine that the men who are listening have just crossed their legs. Really effective because it's a local treatment, but yes, it involves an injection of a small amount of medication into the side of the penis, but it works because it's a local reaction.
Are there side effects apart from the what you mentioned about the heart and people that having heart issues not taking Viagra, are there other side effects of taking these types of pills? Like, and also the cost. You mentioned that both the implant and the pills are really expensive. How much money do these things cost?
Right. So not the implant, the little pellet. It's called Muse. Yeah, okay. It's called Muse. I mean, there also is a penile implant. I mean, that really is a method of sort of last resort, because it's big. It's really big surgery, and most men don't want to go for that. So the pills cost around $12 to $15 per pill. Makes me crazy, because they've been around for, well, 99 in Canada, 98 in the US. So somebody do the math, but I think that's a long time. Mm-hmm. So that, and their Viagra certainly, I think, is the best selling medication of all time. So there really is no reason why it should be so expensive, but it is. You can get generic versions, but unfortunately what happened was, let's say the generic version came in at $12, the trade Viagra charged $12 as well. I mean, honestly, I think it's highway robbery, and it really disturbs me. I personally have been to Manitoba Health to advocate for this medication to be covered, just the same as the other medications that treat side effects of cancer treatment. And frankly, I got nowhere. So, speak to your MLA if you are brave enough and raise this issue. If enough people shout about it, maybe they will do something. So there's the expense of that. We know from larger studies, not necessarily just in men with prostate cancer, but men generally, a very small proportion of men refill a prescription for these medications. Men are often not educated in how to use them properly. The medication does not cause an erection, and this is where there's a lot of misunderstanding. All that the medication does is that it prevents a reaction at the cellular level that causes the blood vessels to constrict and push blood out of the penis. So there has to be penile stimulation in order to get blood in there in the first place. The other side effects of these drugs, because they cause the blood vessels to open, nasal stuffiness and congestion, facial flushing, and some men get a cracker of a headache. It's all related to blood vessel dilatation. And what makes common sense? I'm congested, I'm going to take something like Sudafed or a decongestant. That actually acts against the Viagra. So if you can push through the congestion, it will go away. The facial flushing is just that. Some men also get some heartburn. So I advise them, if that happens, just chew a couple Tums at the same time as you're taking the pill. And if you get a headache, take a couple Tylenol at the same time as you take the Viagra. But yeah, they certainly. Oh, the other thing is that because they lower blood pressure, don't jump out of bed, and rush for your cigarettes. Don't smoke at all. But you just be careful, getting vertical after being horizontal because of that drop in blood pressure.
So, given all of that, is it worth even trying the Viagra or Cialis if a lot of people don't have much success with it sounds like, or that there's.
Yeah, I mean, I think it's worth it because, and most men think it's worth it because it's easier to take a pill than to stick a needle in the side of your penis, quite frankly. So yeah, I think it's worth a try. And I tell men you have to try it on 5 to 8 separate occasions before we can say that it doesn't work. If you can't stand the side effects, if you get a terrible headache, for some men they get some blue vision, and that's also sort of something complicated. It's not because the pills are blue, it's because the receptor for the medication is next to a receptor for something else complicated. That's just kind of perhaps a little bit irritating, but some men get such a bad headache, and pain and sex are good for a very small percentage of the population. So if you have side effects that really are sort of untenable, look for something else.
So somebody's written that no amount of touch and intimacy can help in terms of producing an erection. Is there what other options does this person have?
Injections or a penile implant.
Okay. Does the prostate stop producing semen after radiation therapy, brachytherapy, or external beam?
So it's not the prostate that produces the ejaculate or semen, right? The semen is a combination of sperm from the testicles that go into a tube called the vas deferens. If you've had a vasectomy, that's what's cut, right? So the sperm can't get into ejaculate. So the fluid comes from the seminal vesicles, and the prostate's job is to contract, to push it out. And the prostate actually also provides some enzymes that make the semen, the ejaculate, more liquid. So what we tend to see with that is much like the changes that happen with aging, but we tend to see a real decrease in the amount of ejaculate. And for some men, after a couple of years, there is no ejaculate. And I have never heard a partner complain. Just have to say, no muss, no fuss. So, but for some men, it's bothersome. You know, I just want to sort of, while we're talking about ejaculate, and you see how easy it is to talk about this? Yes, some men experience changes in the sensation of orgasm. This happens particularly after surgery, but it also can happen after radiation therapy. So some men experience the same sensation of orgasm as they always have. Some men experience a real decrease in the pleasurable sensations, some to the point of it's kind of a non-event. And some men actually experience much more intense orgasms, some to the point of pain. And they can have this sort of achy feeling for perhaps a couple of hours after that. We think this is mostly related to the pelvic floor. So, you know, if you have a really tight pelvic floor, because even though the physiotherapist told you to do the exercises 3 times a day, you decide that you're going to do them 6 or 9 times a day, which men often do. You land up with a really hypertonic, very, very tight pelvic floor. And a lot of the sensation of orgasm actually comes from muscles of the pelvic floor. So, you know, if you come to me with that complaint, I send you right back to the pelvic floor physiotherapist for an assessment, and perhaps a little bit of a educational session about only do the exercises as you've been told.
A comment that someone wanted to share was that they had selected I'm glad to be alive in place of none of the above. So I guess that they had, they had written that. And then they also added they were happy to talk to someone and get help. So that's nice to hear. In terms of those people that aren't in relationships, like we've talked a lot about, you know, how couples are affected, but if somebody's single and they're having erectile dysfunction, or they're just feeling really self-conscious, how do they approach dating when they're concerned about these issues?
Yeah, you know, that's really a big one. And I have, you know, over the 20 or so years that I've been doing this, I've certainly seen a number of men who are really distressed about this, think that they have nothing to offer. You know, don't even try to meet somebody, which I know is really difficult, and COVID certainly hasn't helped. And you know, are spend the rest of their life alone. Now, some people choose to do that, and that's absolutely fine. But you know, if you do that because you're afraid, or you think nobody will want you, you know, one of the things that I will often talk about is you know, say to the man, well, sort of what age range are you looking at for a partner? And you know, a 69-year-old man generally isn't looking for someone in their 20s or 30s. So women of a similar age generally have gone through menopause and don't necessarily have the same interest in penetration. But you know, erections are very much tied up in masculine self-image, in masculinity. I think in a very similar way to our breasts are for women. And you know, so this fear of nobody's going to want me because I can't have erections, you know, is very real. You know, what can you do about it? I mean, certainly, you know, try Viagra. I mean, nobody needs to know that you're taking it. You know, I believe in honesty, and certainly, you know, if you need some help in that department, I think it's worthwhile disclosing to a potential partner. You know, young people with cancer have the same kind of issues, right? How do you tell someone you've had cancer? I think, you know, perhaps one of the benefits of of aging or being older is that, chances are anybody you meet will have known someone who's had cancer and will have some understanding of the changes in life, sexual and otherwise, right? And I think there are some positive changes after cancer, a greater appreciation of life, not taking things for granted, having that sort of thought that we so often have when we're younger, that we're going to live forever, that we're invulnerable, right? Which obviously isn't true. So certainly personal growth is very much a side effect, perhaps a positive side effect of having cancer. Many people now are going online to meet someone, and I think that it really it perhaps gives a little bit of distance, which perhaps makes it easier to tell someone that you've had cancer, and that can weed out, right, the people who are going to reject you solely on that, which I think is unfair.
Mm-hmm. And Dr. Katz, do you see a lot of people in your practice that are single, and are there specific issues with the single people that you meet? And
yeah, I see a wide range of men, some single, certainly some partnered, in my practice. I think the partners, provide real benefits, right, beyond cooking and that kind of stuff, but they provide support, right, and being able to bounce ideas off somebody. And when I want to see a partner involved in treatment decision making, because it's going to affect them as well, and they have a right and a need to have the same information as the man. And things sometimes get lost in translation, right, because physicians will often, give you a whole lot of information using medical language that perhaps, you're not familiar with. Often they'll talk really, really fast, and often they'll provide you with a whole bunch of statistics and research says this and blah, 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 blah. And, it just becomes kind of word soup. So, bring your partner with to appointments. And I know this is a problem with COVID, that we're restricting the number of people in the building, but certainly for a first visit, when you hear about the treatment plan, your partner should be with you, and they can be on the phone. I mean, that's the other thing. So bring your cell phone and say, is it okay, if I have my partner on speaker, so that they can hear, what you're telling me. Some people ask to record that appointment so that they can go over it afterwards. You always have to ask permission. I think it's just, it's polite. It's the right thing to do. Don't do it surreptitiously with your phone in your pocket. I don't think we would give information that's any different, but it's just common courtesy to say, is it okay if I record this? Because some people don't like it. I'm fine with it, right? Where were we? Partners,
yeah, just talking about single people, and I guess them not having having the lack of support, emotional support, and a sounding board to bounce things off of, and then the challenge of entering a new relationship if there are some sexual challenges as well, and how do they disclose that? What about for gay men? Are there specific challenges for them that you've experienced?
Certainly depending on, what their sexual repertoire is, for lack of a better word. So some men have said to me, I'm the receptive partner for intercourse, so my lack of erections isn't really a problem after treatment. If the man is the insertive partner, certainly there can be some issues. People often assume that all gay men have anal intercourse, and they don't. So I certainly am very comfortable, and I have a number of gay men as patients. I'm really comfortable talking about any and all things, and I think it's really important to disclose, right? Because we need to know this so that we are respectful, and certainly there is no problem if you want to bring your same-sex partner to an appointment. We treat your partner the same as we would treat any partner.
And do partners sometimes have difficulty asking for what they need and want, especially when they know that their partner is going through cancer treatment, and they might feel like that it's selfish of them to be wanting sexual intimacy when they know that their partner's not feeling well or is going through this treatment process. What advice do you have to give to partners so that their needs are also being met and communicated?
Yeah, this can be really, really difficult, right? Because we tend to protect our partner's feelings, and we don't want to say anything that could be, could be hurtful or demeaning or whatever. And, this is why communication is so important. And why, using I statements. People, often say to me, how do I talk to him about this? First of all, I will sometimes actually see the partner alone, so that they can ask questions that perhaps they just don't want to ask in front of the man because they don't want to hurt his feelings or whatever. So sometimes that's helpful. But there's this very interesting thing that happens, and Kathleen, you'll know about this because you work with many of our psychosocial clinicians who do counseling as well, not necessarily sexuality counseling, but about coping, etc. That there's this interesting phenomenon that when there is a couple with an objective professional like me or one of the psychosocial clinicians, the couple communicate. And sometimes I sit there thinking, could I check my email? Of course I wouldn't. Could I go get a cup of coffee? No, I won't. But I often see with just a couple of questions, the couple will start talking to each other. They turn, in my office, pre-COVID, everything's pre-COVID, right? They would actually turn their chairs towards each other. And I just kind of sit there as a very happy observer. I will certainly intervene if things get heated. But I've actually never seen that. What I really have seen is sharing and kindness and sensitivity, which, makes my heart feel good.
I think that is one of the nice things about therapy, is that when there's a third person in the room, there's a sense of safety, and that you can talk about things that you might think, if that person weren't there, this could get heated, or this could feel like a criticism. And yet when there's a third person in the room, sometimes it just feels like you can then talk more freely. There's a comment from one of our viewers that mentions that he's had 20 radiation treatments and is supposed to have 30 plus treatments. Mentioned that he had gold seed implants prior to radiation, and he's wondering if that is different from the ones that you mentioned for brachytherapy.
Okay, so the radiation oncologist, based on a whole number of factors, will decide how many treatments the man has. So for some men it's 20, for some men it's 36, for some men it's 42. For some men, it actually might be as few as 5, but that's for different reasons. So one is not inferior to the other, right? It's just based on the amount of radiation that they want to give, and it's divided into different, what we call fractions, and that then decides, how many actual days that the man has to come in for the treatment. Yes, so the little gold seeds are called fiducial markers, and there are 3 placed into the prostate before radiation treatment starts, and those are helped to guide the radiation beams during the course of treatment. So as the prostate responds to the radiation, it can move slightly. And so with those gold markers or fiducial seeds, that will show us, because we can't see what's happening in your body during the radiation, but they can use those as guides for where the treatment should be targeted to increase accuracy and minimize damage.
Okay, this person also
we do that routinely. We do that routinely now for external beam radiation.
Okay. And thanks for clarifying that, because I thought too maybe they were a type of brachytherapy as well, because they use the term seed. This person also writes that they've had more success in standing while going to the bathroom versus sitting. And he's asked, is that a different issue happening?
Everybody's different, right? And your body, it responds differently. And What's important is that you find a way of emptying your bladder in a way that's most comfortable and effective for you.
So that is affected from radiation, just the ability to
not necessarily, not necessarily. I mean, there's differences just in our own anatomy. So, my sort of rather flippant comment about sitting was because there's less chance of some dripping on the floor or on the toilet seat. But it doesn't work. It doesn't work for everybody.
Just going back to the incontinence issue, what about incontinence during or leakage during sexual activity? Is that a common occurrence as well?
Yeah, that's not uncommon, and there's a reason for this, right? So after surgery, when those muscles of the pelvic floor are taking over the function of that sphincter or valve that keeps the bladder closed, during arousal or during orgasm, those muscles can kind of give way, which kind of makes sense. And so there can be some leakage when you become aroused or during sex play. Or for some men, they have leakage during orgasm, and when the muscles of the pelvic floor are contracting, once again, that's also easy to understand why that happens. It's so common that it even has a Latin name, and it's called sorry, I've actually forgotten it, right? This climacturia. I'm sorry. There we go. I knew it would come eventually. Climacturia. So if it's got a Latin name, it's a common occurrence. So urine is not going to damage your partner in any way, but it's kind of embarrassing. And obviously for oral sex, that is problematic. So, the common answer that people say is, well, just wear a condom. Well, that's not necessarily that easy, because you have to have a really rigid erection in order to use a condom. And, men tend to have a bit of resistance to using condoms. So that's problematic. Certainly, there are some surgical solutions to this. So there's something called an artificial sphincter, which is kind of almost like a donut-shaped device that is placed internally around the urethra, and it's contracted normally. And when you want to urinate, there's a way to kind of deflate it, which will allow urine pass. That's a surgical procedure, but certainly it is available as well. Certainly urinating, before you start fooling around, can be helpful. Some men will actually limit the amount of liquid that they drink for a couple of hours beforehand, so that the bladder is empty. Those are sort of, the kind of commonsensical things to do.
Okay.
Using couple towels to protect the, the bed sheets and the mattress, but it's distressing.
Question about internal beam radiation. This patient was told that it will go through their rectum. Does that affect them more? Will that have other side effects? Yeah.
I don't understand. Is this brachytherapy?
Yeah, the question was, what about internal beam radiation? I was told that it will go through my rectum. Does that affect me more?
Okay, I don't know what internal beam radiation is. External beam radiation, certainly the beams of radiation go through your body 360 degrees around the body, and so the rectum is certainly exposed, but the amount of radiation to the rectum is limited. So internal radiation is the brachytherapy. And there the seeds are placed using really long needles. The man is under general anesthetic, so don't panic. But the little seeds are inserted via long needles that go through the perineum, which is the area of the body behind the scrotum and in front of the anus. And very little pain associated with that when you come round from the anesthetic.
Okay. Thank you for clarifying that. A lot of this sounds, even to me listening to it, sounds like it would be incredibly stressful. And I'm just wondering about, just the stress of the whole journey of prostate cancer, what impact that has on libido. We've talked a little bit about that, but when you're in your counseling practice, do you hear a lot of that discussion, just in terms of feeling stressed, feeling frustrated, feeling depressed?
I mean, certainly for some men, and I think a lot of it is because of lack of information, lack of anticipatory guidance, um, perhaps some magical thinking. We tell people, and this happens to all of us, right? We tell people all these horrible side effects, and certainly, some men think, oh, that's not going to happen to me. It's going to happen to everybody else but me. So certainly that can cause, some stress. I think any treatment for cancer causes stress and distress. And the diagnosis itself, right, turns your whole life upside down. And cancer is an experience of uncertainty, right? I think, most of us go through life thinking we know how things are going to play out. And along comes cancer, right? And everything changes. So, certainly I work closely with the psychosocial clinicians. So, if I see somebody who sounds to me like really is depressed, perhaps not coping well, I will certainly offer a referral to a psychosocial clinician, just as when they are seeing our patients and the man is experiencing some sexual issues, they refer to me. So once again, we're a team. I certainly will often send a note to the family physician, obviously with the patient's permission, saying, this gentleman doesn't seem to be coping well. He's, he has some signs of depression. Would you talk to him, and maybe an antidepressant would be appropriate. Maybe he just needs to get some exercise, because we know that exercise is effective in treating mild to moderate depression. The depression, anxiety, etc., tends to be situational. Honestly, once again, I see people who are engaged, right, and want to make some changes. And it's one of the things that this work has taught me is that the human spirit is just so powerful, and people get through things that I'm in awe of, and I think sometimes they're surprised that they get through this.
Yeah, definitely. In terms of antidepressants, there are some side effects of them sometimes that can cause some sexual issues too, right? Some antidepressants?
Yeah, so some antidepressants cause loss of libido. Some antidepressants make achieving orgasm really, really difficult. But there's a wide range of antidepressants, and some work better than others. Some have better side effects than others. Sometimes you can use a combination. There's one in particular called Wellbutrin that they suggest is actually pro-sexual. Depression often impacts on sexuality anyway. So, this is an individual discussion that should happen with somebody's family physician, because they know you best, right? We kind of know you from below the belly button to the top of your thighs. So that really is the role of the family doc. And I really, often when people are going through treatment, they kind of lose connection with their family physician. And I think that's a shame. Because, honestly, we're not going to do much about your blood pressure, just saying, or your cholesterol. You really do need to be in regular contact with your family doc about that.
I just wanted to invite our audience to feel free to ask any more questions. We're kind of getting close to the end of our discussion, but we do have a little bit of time, and I did want to ask you, Dr. Katz, about some of the couples issues in terms of creating sexual intimacy without necessarily intercourse. And one of the terms that I've seen you talk about, or heard you talk about in podcasts, is sensate exercises and the importance of touch. Could you talk a little bit about that?
Sure. So human beings need touch. So many couples, the only time they touch is when they're being sexual with each other. Many couples say to me, we still kiss and canoodle, and we sit on the couch and we hold hands. And when we go for a walk, we hold hands, and, we have a kiss good morning and we have a kiss good night. And, that's obviously great because of that need for touch. So, one of the things that may happen is when, erections are not happening, intercourse is not happening, touch stops. In part because of that, that weird dynamic that people get into. I don't want to lead my partner on, the partner says, I don't want to, put pressure on him. And the result is a couple that's living like brother and sister. And I know I certainly wouldn't choose to live with my brother. So, for some couples, that's okay. And everybody is different. But, when people sort of start to get a little bit squirrely and they're sniping at each other, often that's because touch has gone away, because touch produces oxytocin, which is the hormone of bonding. There's nothing romantic about this. It's just about hormones, people. So touch is really, really important. And once again, communication. Sometimes the partner may have to say, I need a hug. Right? And I think particularly for men who are on androgen deprivation therapy, where the motivation, the impulse to even hold hands just goes away, right? And because of the lack of testosterone. And so you got to use your words. Human beings have the ability to communicate with language. Got to use your words.
Could you say a little bit about the difference between responsive?
Sorry.
Yeah, go ahead.
Sorry, sensate focus. I have to talk about this just for a minute. Right. I'm sorry. Yeah. Yes.
Yeah.
So this actually comes from Masters and Johnson, and sensate focus exercises or sensual massage, because that's really what you do, is a series of homework exercises that we teach couples, where intercourse. So there are 4 stages. And intercourse only happens in stage 4, if at all. But it is a way of encouraging couples to touch each other in a really meaningful and purposeful way. And it's often really effective because, it's homework. And I'm telling you to do this. So it takes away that sort of the one person having to initiate or ask for it. So it's a series of exercises that get more and more erogenous, shall I say. So in the first stage, and generally if you're doing this, we recommend 3 times a week, which is a lot, I know, because like golf and grandchildren get in the way. But generally, if you're doing it 3 times a week, you stay in each stage for 2 weeks. And in the first stage, there is no genital touching, there is no breast touching. And the focus really is not on what your partner is feeling. And this is where people really sometimes, don't get it right. The focus is not on what your partner is feeling. Your focus should be on what you feel when you are touching your partner. It's a very mindful way of touch, and it sort of gradually gets more and more, there's more genital touch, etc. But this is not goal focus. This is not, you need to be in stage 4, which involves penetration. Some couples stop at stage 1 or stage 2. That's really what that is.
And could you talk a little bit about the difference between responsive rather than spontaneous desire? It sounds like it has something to do with this practice as well, of these exercises in some way, but
yes. So responsive desire really has sort of describes the female sexual response cycle perhaps more than the male sexual response cycle. There certainly is some research now going in to see if men, particularly men who've experienced cancer, actually will have something similar. So I don't want to get into a huge amount of detail here, because we really don't know how applicable this is to men.
Discordant desire, that's another term that I've seen in, I think, in one of your, or maybe heard in one of the podcasts that you've done. And is that just a difference in libido? And
yeah, it's a different level of desire. So sometimes it's in a heterosexual relationship, it's the male who has a higher level of desire, but not always, right? And sometimes it's the woman who has a higher level of desire, and this can impact quite significantly on relationships. I think particularly when the man has a lower level of desire, because the social trope around desire is that men are like the Energizer bunny, right? Always ready to go at a moment's notice. you know, and that is not accurate at all. You know, men are sensitive creatures, and, you know, have the same, you know, sort of psychological issues. If you're stressed at work, you know, for some men, they become very interested in sex because for 10 minutes, they don't have to think about anything else. But for some men, it means that, you know, desire goes out the window because they're dealing with, you know, stuff, illness in a child, even an adult child, extremely stressful.
So discordant desire is an issue in relationships, whether there's a cancer diagnosis or not, that there may not be they may not be in sync in terms of how much they,
yeah. And generally, you know, it's something that's spoken about in a non-cancer affected relationship.
Right. Another question from one of our audience here is sperm after cancer treatment harmful to my partner?
Nope.
That was definitive.
Yeah, no, nothing, no.
Nothing at all. Okay. We're just about out of time. So if there's any last questions, please feel free to type that into the Q&A. I did want to show an example of two of the books that we have by Dr. Katz that are in our library: Man, Cancer, Sex, and Prostate Cancer and the Man You Love. And I understand that there's a new edition.
There's a new edition coming in November. So I have completely rewritten Prostate Cancer and the Man You Love because I hate doing a revision of a book. So I completely rewrote it. And, you know, obviously updated all the information. So that's coming out in November. I'm very excited about it. It's got a very cool cover, I think, because I chose it. And it really was a labor of love. So I wrote it during COVID.
Oh, wow, good for you.
It's my COVID baby. I wrote another couple of books during COVID as well, but that was a real passion project.
There's just no stopping you with your I don't know how many books that is. I know that it's over a dozen, but I think I lost count just trying to.
I think it's 16 now.
16.
I think so.
That's great. Well, you're a wealth of information, and it's really enjoyable having you.
Kathleen.
Yes.
Before we leave, I want to give people my phone number. It's my direct line in my office. You do not need a referral if you want to see me. You can just call me. It's called a self-referral, and I don't turn anybody away. So my direct line is 204-787-4495. I am at my desk at 6 o'clock in the morning. Yes, I am weird. And the best time to reach me actually is between 6 and 9 in the morning, because I only will start patient appointments at about 9. That means that I leave sort of around 2 o'clock. So if you call me at 5 o'clock, you can be sure that you just have to leave a message. And I know sometimes I answer the phone and there's this sort of stunned silence because I actually answered. So if you want to just leave me a message, call after 2. Otherwise, call between 6 and 9, and that is my direct line.
If you're up that early. Set the alarm.
Because it's the best time of day.
It is lovely. It is a lovely time of day. So Ellie has shared that phone number in the Q&A in case anybody missed that. And feel free to contact the Patient and Family Resource Center here as well. And we can provide that information as well as lend you any of Dr. Katz's books that we have here in the library. So thank you again, Dr. Katz, and thank you to everybody for joining us tonight. And please feel free to contact us if you'd like any information. Thank you.
Thanks for having me. Bye, everybody. Thanks. It's still light outside. Have a good evening.
Take care.